We sent several months ago a series of lectures on how to talk to the patient who has a lump in their thyroid and is probably, again, at some point need thyroid surgery. How much do you do in your first visit? How much do you do in your second visit? What about family? Things like that. So we're going to do two parts. One is basically reviewing all the approaches and questions that you need to ask. And second, I'm going to actually do a fake discussion as if you were a patient and I was giving you my pre-op consultation in the mood and how I do that. So there's going to be 10-15 minutes of me just going over some questions and 5-10 minutes of how quick you do it in the office, because it doesn't take 45 minutes. It should take you 10 minutes to be able to do it in your office. So basically, patients are referred to you having seen another physician almost always, occasionally a family member, but 99%. Another physician has found a thyroid nodule, and it can come anywhere from an extensive investigation with biopsies and ultrasounds and things like that, but the vast majority of them come from a family doc, and they come in with a lump in their thyroid gland, and they are referred to you for the workup. So what you need to be doing is not just starting with the investigation, but getting them so they trust you, and starting the sequence of events and letting them know, here's kind of the big picture of how these things go, from the workup on today's visit and the things we're going to talk about, and the tests that I'm going to do, all the way to when you come back with those test results, who do you want with you, and might you want other people, and things like that. So it's easier with your patients if you kind of warn them up front, this is how a basic ENT thyroid visit is going to go. For the physical exam, I always sit them down, and there are two questions. One was, are you going to go in front of them and put your hands on them? But they're usually down here, and in my exam, I've always stood behind them and put hands back here. I always got a better sensation of parathyroid glands, if I could actually find one, finding the cartilages of the larynx. I frequently went through and found all the normal stuff first. I want to go the SCMs and the clavicles and the larynx and the jaw and all the normal muscles. And when I found everything, then I go feeling for thyroid. And occasionally when you're doing your everything exam, you're going to find a lump someplace that isn't really right on the thyroid. So don't go there, don't go off track. Do a normal exam of everything else, then go to your thyroid, and then review this back. And sometimes you will draw a picture, we will go over great detail of how I do pictures. The pictures that I draw on the first visit are pretty much for me. The pictures that I draw on the second visit are a preoperative explanation for the patient, and it's going to be something that they're going to get a copy of that picture. Don't give them the original picture. You can make a copy, and they can both sign it, and they can have it. But when they come in for their second visit, it's going to be a much more detailed picture, and it's an explanation, and it does two things. One, it really makes you a much safer person if they go to the operating room and one of the complications that you were going to recommend actually occurred. They knew it, they signed it, you're covered. And so, one, medical legally, it's safe and it makes it safe for you. And number two, they will show it to their friends, and their friends will come to see you, and you'll be a busier doctor with more dollars. So it is advertising. So even though you may not be an artist, I am not an artist. I don't draw anything else. I really don't enjoy art. But I have practiced all my ENT drawings of the ear, of the nose, of the mouth, of the larynx, and the thyroid is one of them. And so it's something you can sit and practice about 10 times, and you'll have it when you do that. So what you want to do, number one, get the basic ideas of what's going on. You're going to get most of your information from the tests that you order and the blood tests, but you really want them to have great confidence in you. There are other thyroid people in town. You want these people to trust you and want to come back to you, and they liked how this thing went. So you've got to be listening to them and watching them and knowing how far to go and how far not to go. I then go send them off, as you know, for a thyroid scan, and usually in the ultrasound, the tech, if I sometimes have my own machine and do them myself. Most people don't do that much anymore for insurance reasons. But a biopsy, if needed, and it's the places the radiologist will go ahead and do that. They really shouldn't go someplace, have an ultrasound, and then have to come back and have a second visit and have a biopsy. It should all be done the same at the same time. I am frequently sending them off for their thyroid blood tests, which is going to be how their thyroid hormone is doing and how TSH is doing, and I always send off for the calcium levels, just in case on the long shot this turns out to be some parathyroid thing. Get PTH and get a calcium level so that if there's a big surprise, they will be impressed and you won't have to go order another entire test. When they come back, you should have it all right. One way to play the game is see if you can check all your blood tests before they ever show up, so that they don't show up in the office and then you find an abnormal test and then you have to send them off again for another day. You really want them to come back and have it ready to go the second time. Their second visit. When they come back for the second visit, they kind of know there might be something going on and there's going to be an explanation for what's happening. And frequently they are bringing family, so you need to be prepared to speak with family. One example here is the patient comes in who has something scary and they are crying. If somebody comes in and they are crying during the exam, anything that you say is not going to go anywhere and it's not going to be worth anything, and for, again, medical legal reasons, they will say, I don't remember hearing any of that. So you have two options. If they are all alone and they are crying, I frequently will just let them go on home and I do not charge them for the visit. And I have them come back at another time, letting them know I'm going to give you this information. You may want to have family and I'm going to tell you everything next time. And I think they really appreciate it if you send them home and they haven't been charged, and when they come back they've got the appropriate friends. One problem along that is if somebody comes in and they have somebody with them, and at the beginning of the discussion they come up to you and they say, don't tell much to my aunt so-and-so who's here with me. She really doesn't need to know this. That's a problem. That person's in the room and you want to talk to your patient, but they don't want this person to know it. So I divide it into two exams. I say, ma'am, we're going to do the basic exam, but then I always talk to just that patient, kind of as if that's really what I would do. But that way you can at least, if you have to say something, you can have the family leave. Obviously, during your second visit, it's going to be all about how you're going to go to the operating room, what the risks are going to be, how the overnight stay is, and again, that's going to be a second thing that we're going to talk about here. One last topic before we go through how I do this operation. Occasionally, you will be working on an executive business person or an attorney or somebody who thinks they are kind of in control of things. And they know that they don't understand all the technical details of thyroid. And they know when you're going through parathyroids and recurrent laryngeal nerves and things, that whoo, it's shooting by them and they really are not getting it. Even though you're giving them a drawing and they're going to take it home and they can ask their friends. And a lot of them ask you not to do that and just move on and tell them what you're going to do. That's not the way to play the game. To play the game is to tell them, for medical legal reasons, I still have to say this stuff. So if you don't want to listen, you don't have to. But I'm going to say a variety of things of how I'm going to go and what I'm going to do, and I'm going to give you an explanation, and you'll sign it, and I'll give it to you. And if you don't really want to listen, you don't have to. And I have some patients who kind of just read a book, and they kind of turn away, and I go ahead and give the whole talk, so that if there's a complication and you're doing a surgery and they have a paralyzed nerve, their family can't get upset. The family, you can say, I explained this in great detail, and they understood, and there's no questions about it. So as you may have guessed, I came from a family of lawyers, and so we just know how to handle yourself legally. So what we're going to do is switch now to how I draw the drawing of the neck and the thyroid gland, and how I do an entire explanation as if you were a patient and as if you were here having had all your tests and you had your results, and I was now going to sit down with you and any kind of family that you had and give you the explanation of what's going on. So we're going to keep this thing going, but now you're walking in the door and you're sitting down, and I'm going to say, hello, Mr. Jones, it's nice to see you, and Mrs. Jones, nice to see you. It's interesting that you brought your kids with you. It was nice of you to do that. I do have all of your test results. I have all the blood tests, and I did talk to you on the phone a little bit the other night when I had some of those tests. Now, see, I am talking to the patient now, as if you were the patient. I did give you some of that information, so I'm going to go through a whole detailed explanation of what we're going to do and why we do what we want to do. You can stop me if you want to. It's a little better if you let me go ahead and explain it, because a lot of the questions that you may have, I'm actually going to answer as time goes on. So let me draw you a picture of where the thyroid gland is and what we're dealing with, and then what we're going to do, and that'll make sense for you. So the thyroid gland again, trick for residents, I always make a drawing of something that they don't know what this is because other people aren't really paying attention. And if you draw this does not look like a thyroid, and it makes them look at you and you get their attention. And now that you've got them, you can continue. But I start with that, this, and then I draw thyroid. That is your normal thyroid gland, and if family is still looking at you with funny eyes, then I go, that's all, just those 3 dots, and they all go yes, and they're with you, and they're right with you. I then draw in next to your thyroid gland, there are those glands I mentioned to you, the parathyroid. Those are the ones that take care of calcium, and there are 4 of them. Obviously, if this was a parathyroid case, it'd be a different drawing. And the most important thing are the nerves that go by here. These are the nerves that go to your voice box. This is the right side. This is the left side. I'm looking at you. You're sitting in a chair. This is right side. This is left side. So this is what I'm seeing. The nerve on the right side goes down, goes under the thyroid gland, right up into your voice box. The nerve on the left side happens to go down much further. There's a lengthy explanation for the anatomy of why left side is not the same as right, and if you really want me to go into that, I can, but all textbooks will show you that. So this is, Mr. Jones, this is your thyroid gland, and you happen to have this lump on the right-hand side. So you have I'm going to write plan. You have a right thyroid nodule. So what we need to do is we need to go find out what that is, and we have to be aware of parathyroids and nerves, and the appropriate treatment for this, Mr. Jones, is for me to go and remove the right half of your thyroid gland. So, plan is remove right 1/2 thyroid. While you are asleep, I'm going to send that right half of the thyroid over to the lab, and within 10 minutes, we're going to have one of 3 possible answers for what this turns out to be. Statistically speaking, most of the time, it comes back and they say they had a good sample and this is benign. If they say it's benign, I am done. We sew the whole thing up, we close it up, and we send you home. Outpatient. On the other hand, if they take a biopsy of it and they say it is a cancer, then the correct treatment usually is to remove the left half of the thyroid also. So this is now a total thyroidectomy. Hemithyroidectomy for half, total thyroidectomy. If I have, and if there are, on one of these cases, if the scans had suggested there were lymph nodes, then I have to have a discussion with them about the possibility of neck dissection. And again, if when you have done one of these ultrasounds on a patient and it comes back and it shows with a biopsy it's suspicious, I often, before they come in to see me, go get a CAT scan of the neck so that I don't have to now send them away, get a CAT scan, have them come back and have another discussion. I would like to have all that data so when they show up, I've got all this. But usually, the majority of the time, it is a nodule. It is on one side. They did a needle biopsy. It was not diagnostic, good or bad. We don't know for sure. And so I have done this to find out. A fair amount of the time in thyroid surgery, the little biopsy didn't show, and this didn't show either. The pathologist comes down, maybe even two pathologists come down. They're going to go look at this thing under the microscope, and there's certain criteria for cancer or not cancer. And if they can't make an answer, if they can't tell me for sure, then I'm sending them home. And they know that. They know that there's a possibility. I explained to them. But if in 2 or 3 days, we're going to have our final result. And if it turns out that that is a cancer, then you may need to come back in, have me open up the same incision. Incision is kind of in that area or down a little lower. I remove it and do the other half of your thyroid gland. So I warn them, if I can't make up my mind on that day, there's a possibility that you're going to return. Boy, that doesn't happen very well at all. Depends on how good your pathologists are and if they see a lot of thyroid tissue. But occasionally it happens. You've got to warn the patient. And if it does happen, you bring them back and you go do your thyroid a couple of days later. If it is remove the left lobe, it is overnight. And the reason it is overnight is parathyroid. We have now touched all the parathyroids. We've done our best to preserve all the parathyroids, but frequently the calcium is going to drop, and if calcium drops, we're going to be checking calcium blood tests every 6 hours, and we have very strict instructions giving to the nurses who are examining this on how much calcium and how to replace it. So the patients are warned. This is a risk of working in this area. They kind of were explained a little bit of that the first time they were in the office. We are going to take care of your calcium level, and almost all are going home the next morning. On rare occasion, calcium is still not right, and they have to spend another day to get it right. When I have cancer issue or difficulty with calcium, I get endocrinology involved for sure. The majority of these things are coming from endocrinology. Family doc found lumps, sent to endocrinology. Endocrinology either did the biopsy themselves or sent them over here. But if there's something going on post-operatively, I get endocrinology, and if at all possible, you're going to try to work at a place and with an endocrinologist who's willing to come in and see the patient with you. Not all of them will do that, but if you can, the patients really appreciate it, and it's wonderful for your practice and their practice. And so I've done that for 30 years. I've always had endocrinologists who showed up. So a patient then, when I have written all of this down, then I go talk to them about risks. And I have to find somewhere on this, and we're imagining this is a piece of paper. Let's go over here and say the risks. And the risks are, and you write all this down and explain it to them. There's standard risks in all surgery. There can be bleeding. In this surgery, since we are near the parathyroid glands, there can be calcium issues. And so we will be checking calcium blood tests if you're going to spend the night. Again, write this in such a way that they can read it. I do not have a printed one. It's nowhere near as much fun as if you hand write it out and they watch you write every word, as opposed to a printed thing. There's standard printed ones, and you can just check off the ones it is. You're going to get style points if you hand draw it yourself. One is hormone replacement. One of them is nerve injury, hoarseness. And at this point, I specifically talk with a paralyzed vocal cord. It makes a big point for patients to understand if one of the vocal cords doesn't work, then you'll know that you can't cough and that swallowing isn't right. And I just pop right back into voice. Swallowing isn't right, coughing isn't right. And there are a lot of patients who have a normal thyroid, and we have to kind of push this nerve out of the way because it was wrapped around a big gland, and the nerve doesn't work for a while, but in a couple of days or weeks it comes right back. So don't be alarmed by it, and we don't necessarily have to do something about it, but they need to be aware of that. And I have drawn hoarseness, and I have, on rare occasion, if I see somebody who had a lump that was advanced and it was biopsy proven, and it was cancer, and there were lymph nodes, and we were going to be doing extensive surgery, and this risk is dramatically worse, maybe on both sides, maybe a tracheostomy tube, I mention it. Doesn't happen very often, but if it's a bad enough thyroid that that's a risk, I write and if you're going to do a lot of thyroid surgery, you should be very comfortable and have all your, patients already asleep and necks all wide open, we go do that. So I have all of this information, and at this point the patients really like this. And again, I don't do this on a blackboard. I do it on a piece of paper, and when I'm done, and they have asked all of their questions, I sign my initials, and I make them sign right there as well. I know on the new Epic computer system, even if you have this piece of paper, sometimes it's hard to hide it in the chart and have it in the regular progress notes and have it used by all, but the patients still really like it. I'll show you an example of one. This is a standard drawing. That's everything that we just talked about, every drawing that I just made, every explanation that we had, and everything signed by the patient. Now you can put that in your system, you can include it. I will tell you that the patients love it, and it answers a lot of questions that their family had when Uncle Bob was going to come along and be here today, but he wasn't. And when he gets home, he's going to ask a bunch of questions, and the answers are right here. And indeed, if they have one or two questions, have them call you, have them ask you. Almost never are they going to come up with a question you don't have an answer for. So they walk home with that piece of paper. I somehow get it into the chart so that if there's any, again, if you end up in the courtroom and they're arguing about what did the patient know and what was your plan, this is it. And if during the case you actually have to change plan, if you plan to do this, but now when you've opened it up, you've discovered it's something else and we're going to do it slightly differently, I bring this piece of paper. I explain it to the family who's there. I have them sign it. If there isn't any family, then I just stop the case and we do it as another case later because I don't want there to be a medical, legal problem. Again, sorry, it came from a family of attorneys. But it doesn't happen very often, but it works much better if they're very aware of all the decisions that are made. And again, this doesn't take a long time. The pre-op discussion is 10 minutes, 15 minutes, but they really appreciate it if it isn't just a preset drawing that you're just going to check off a few things. You've seen the drug companies give those away or sell those. It's not the same. So if you have any questions about thyroid and how to do that and how to make drawings, do not call me. Call my daughter Valerie, and she will have answers for you. And if she can't find anything, she will call me and complain to me. So thank you once again.